I'm Karen Sachs, and I'm a nurse navigator with the Life with Cancer program. And we are very happy to present the next in our breast cancer series, Circulating Tumor DNA, What is the Evidence in Breast Cancer? Dr. Kang, who is our presenter tonight, has been with Inova since 2021 and attended medical school in Seoul, Korea. Did her residency at Texas Presbyterian and her fellowship at Baylor. And we're very pleased that she's here with us tonight. So if I can ask that if you have questions, you can either write them in the chat. That would probably be the best way to do that. We will have some time at the end, and if people should so desire to go ahead, you'll be able to unmute and go ahead and ask your question. But I will try to watch the chat as we go along. And we are recording this evening, but just rest assured all the personal information will be deleted. So I guess I will going to go ahead and turn it over to Dr. Kang.
Hello, can you guys hear me? Can you hear me okay?
I can hear you, yeah.
Okay, great.
Yep, we can hear you perfectly.
Hello, my name is Kang. I'm one of the medical oncologists at Inova Schar Cancer Institute. Tonight we are going to talk about circulating tumor DNA, particularly in breast cancer. Okay, so this field is evolving rapidly. More and more patients ask me about circulating tumor DNA in the clinic. So it's definitely a hot topic. I believe that's why it is included in the Life with the Cancer lecture series. For some of you, it may be a difficult concept to understand. I hope at the end of today's lecture, we all have a better understanding on evidence of circulating tumor DNA and also limitations in breast cancer treatment. First of all, we'll spend some time understanding terminologies, the concept of the liquid biopsy, and circulating cancer biomarker, especially circulating tumor DNA. Second, we will talk about clinical applications of ctDNA for early detection of breast cancer and minimal residual disease monitoring after curative treatment, and the usage of ctDNA in the metastatic breast cancer. Then we'll discuss limitations of ctDNA technique and future perspectives. So today's topic is ctDNA, circulating DNA. Let's make sure we all understand the DNA and related terminologies. What is the DNA? DNA is inside the cell. The cell is the basic structural and functional unit of all forms of life. Your body is made up of trillions of cells, and your cells need instructions to create who you are. That instruction manual is in the DNA, and DNA is the molecule or material that carries genetic information for the development and functioning of an organism. Genes are sections or segments of the DNA that code for specific proteins or functional RNA, playing a crucial part in biologic functions. And there are approximately 20 to 25,000 genes in your body. Tumors or cancers are also made up of cells, and at the center of those tumor cells, there is tumor DNA, which contains the genetic code or instructions that control a tumor cell's behavior. A cancer cell is a cell that grows out of control Unlike normal cells, cancer cells ignore signals to stop dividing, to specialize, or to die. As a cancer grows, some of the cancer cells are shed to the bloodstream. Fragments of DNA inside the cancer cells can also enter the bloodstream. The liquid biopsy is a technique to detect these circulating tumor cells or tumor DNAs, which are signs of a tumor. Tumor tissue biopsies have been the standard method for cancer diagnosis thus far. However, traditional tissue biopsies are limited by their invasive nature, potential risk linked with the tumor site, expense of the procedure, difficulties in accessing certain sites, and processing time. Unlike a tissue biopsy, liquid biopsies don't test the tumor tissue directly. It is usually done from the blood test. So there is no guarantee that signs of the tumor will be detectable in a single blood sample. Still, when liquid biopsies detect cancer, they provide valuable information about cancer cells that help your doctor plan treatment. However, tumor cells are not the only cells in the body releasing fragments of DNA into the bloodstream. When cells that are not from a tumor release DNA, it is considered cell-free DNA or cfDNA. Cell-free DNA is released into the bloodstream from various cells in the body, especially blood cells. Circulating tumor DNA, or ctDNA, typically makes up only a small proportion of the total cfDNA in the bloodstream. ctDNA is highly specific and dynamic blood-based cancer biomarker. Circulating tumor DNA dynamics can be used to assess disease burden in real time because of its short half-life, which is about 2 hours. Circulating tumor DNA level is usually very low in earlier stage of the cancer, but if we have a sensitive technique to detect this low level of ctDNA, it can be used for cancer diagnosis or early detection. ctDNA level should be undetected if patient is cured after surgery, for example. Therefore, it can be potentially used to detect cancer recurrence after completion of treatment. Circulating tumor DNA level increases as the cancer progresses and decreases as the cancer shrinks with the treatment. So it can be used to monitor treatment response, especially in the metastatic setting across multiple cancers. Since today's topic is ctDNA in breast cancer, we'll be reviewing the data if ctDNA can be used for diagnosing breast cancer earlier, detecting minimal residual disease after curative treatment, or monitoring treatment response, especially in the metastatic setting. First, can we use a ctDNA technique for screening or early detection? Can we diagnose more cancer earlier just with a blood test? That's a cool concept. Sorry about that, right? Fewer than 20% of cancers in the United States are being diagnosed as a result of screening. Breast cancer has at least a pretty good screening tool, which is mammogram. Do we still need a new screening tool for breast cancer? Maybe, because mammogram is not perfect. A mammogram has limitations, meaning false negative and false positive results. A false negative mammogram looks normal, even though breast cancer is present. Overall, screening mammograms miss about 1 in 8 breast cancers. Women with a dense breast are more likely to get false negative results. False negative mammograms can give women a false sense of security, thinking that they don't have breast cancer when in fact they do. False positive mammogram looks abnormal even though there's no cancer in the breast. Abnormal mammograms often require extra testing, such as diagnostic mammogram, ultrasound, and sometimes MRI, or even a breast biopsy to find out if the change is actually cancer. And about half of the women getting annual mammograms over a 10-year period will have a false positive finding at some point. False positive mammograms can cause anxiety. They can also lead to extra tests to be sure cancer isn't there, which causes time and money and maybe even physical discomfort. The use of liquid biopsy is a promising option for improvement in screening, but low levels of ctDNA in early breast cancer may be challenging. Using circulating tumor DNA for early cancer detection is still in its beginning stages. The DETECT-A study was the first ever large prospective interventional study to use a blood test to detect multiple types of cancer in a real-world setting. The DETECT-A study enrolled about 10,000 women with no history of cancer to determine if a blood test in combination with the standard of care screenings could detect cancers before signs and symptoms appeared. Cancer-sick blood panel was used in this study, and it is designed to combine ctDNA and protein biomarkers to increase the detection rate, because only less than 50% of localized early-stage cancers have detectable levels of DNA mutations in the blood. In this study, patients underwent a baseline blood test and scored positive if any DNA or protein analysis were above preset threshold. They underwent a confirmation test to make sure detected DNA mutation was not from other normal cells, such as the blood cells. Those who scored positive on baseline and confirmation tests underwent an imaging test, generally diagnostic PET scan, to localize the cancer if present. Participants whose PET scan showed features concerning for cancer were referred to specialists for further evaluation and treatment. And all participants were asked to complete detailed surveys at 12 months following enrollment. So this is the result. Remember, about 10,000 healthy women were enrolled. Out of those, 26 cancers were first detected by blood testing. This picture on the left shows various types of cancers first detected by cancer-sick blood testing. The right-sided picture shows all the 96 cancers that were diagnosed in the study. The blue color represents cancers first detected by blood testing. The green color represents cancers first detected by other standard screening methods. As you can see here, only one breast cancer was first detected by blood test, and the rest was detected by standard of care screening. So sensitivity for breast cancer was quite low, about 33%. So this kind of test should not give false reassurance and decrease adherence to standard care screening, particularly mammogram. In this study, 98 patients had positive blood tests, but 96 remained free of cancer with a median follow-up of four years, which gives a false positive rate of less than 1%. Initial data with this cancer-sick blood testing was published in 2018. It was thought to be very promising. 5 years later, in 2023, it is still not implemented in routine practice. However, ctDNA is a fundamentally new approach to the screening and detection of cancer. Technology is improving, work is still progress. So this is just one of the examples. Exact Science is the company that runs Oncotype test, which is widely used for hormone receptor positive breast cancer. And this Cancer Guard multi-cancer early detection testing is in their pipeline. So stay tuned. Let's switch our gear to minimal residual disease monitoring. What is minimal residual disease? It is cancer persisting after treatment that cannot be detected with the current imaging tools. In other words, it's occult metastatic disease. Minimal residual disease detection is more commonly used in blood cancers, such as leukemia or multiple myeloma. We cure most of early breast cancer with the surgery, chemo, and radiation. If so, why are we talking about minimal residual disease in breast cancer? It's because that up to 30% of women with no evidence of disease after curative intent treatment will eventually relapse and succumb to their disease. Existing tools are inadequate at identifying recurrence early before the patient becomes symptomatic. If we have a better tool to identify high-risk patients who need intensified or extended adjuvant therapy, we may be able to cure more patients. What methods or tools are currently used to predict risk of relapse or to measure disease burden after completion of early breast cancer treatment? We look at patients' age, tumor size, lymph node status, and etc. to stratify their risk of relapse, but these risk features can be subjective and may not correlate to outcomes after treatment. We have protein tumor markers such as CA15-3 or CA2729, but these are not good markers, meaning a tumor marker can be elevated when there's no recurrence, and it can be normal on many occasions, even in metastatic patients. When this tumor marker is elevated and seems to reflect disease burden, this protein biomarker helps. But a lot of times it is not a reliable marker. What about imaging? In my clinic, I get these questions all the time. Dr. Kang, when do I get my CT scanned? Why don't you order PET scan? I'm worried. But CT or PET scan can only detect the cancer that has already formed a measurable mass. It cannot detect micrometastatic circulating cancer cells. Due to these limitations with the imaging technique and the potential radiation exposure with unnecessary CT scan, current National Cancer Treatment Guideline recommends against routine imaging in the absence of clinical signs and symptoms suggestive of recurrent disease. But the reality is we're all worried about potential minimal residual disease after curative treatment. Can circulating tumor DNA monitoring solve this problem? Let's look at the data. So, EVLIS study is the longest ctDNA follow-up study to date, exploring the potential use of circulating tumor DNA monitoring in patients with high-risk breast cancer. 188 patients with a primary breast cancer were recruited following surgery and adjuvant therapy and were followed up for up to 10 years with a semi-annual blood sampling for circulating tumor DNA analysis. In 156 patients, blood samples were retrospectively tested for the presence of ctDNA. And this is the results. The green line represents relapse-free survival in ctDNA negative patients, and the blue line represents relapse-free survival in ctDNA positive patients. The gap between these two curves become larger and larger over time, meaning ctDNA positive patients eventually relapse. Longitudinal testing identified ctDNA positive patients with a 52 times higher risk of relapse compared to ctDNA negative patients. And this ctDNA was detected ahead of clinical or radiologic relapse in 30 of 34 relapsed patients. How much earlier? On average, about 10 months earlier. And this is just one of the studies showing positive ctDNA as a marker for recurrence or metastasis. However, what do we do with this information? If we detect disease recurrence 10 months earlier, before CT scan shows abnormality, can we do something differently for those with a positive ctDNA when imaging is still negative for any measurable disease? Can we help patients live longer by intervening earlier? This is still a difficult question to answer. CTRACK-TN is the first prospective study to assess whether ctDNA assays have clinical utility in guiding therapy in triple-negative breast cancer. This study enrolled patients with a stage 2 or 3 triple-negative breast cancer and residual disease following curative treatment. Stage 2-3 triple-negative breast cancer patients usually receive chemotherapy prior to surgery, and if they are found to have residual disease at the time of surgery, it means chemotherapy failed to kill all the cancer cells. So it confers high risk for recurrence. These high-risk patients had ctDNA monitoring every 3 months for 12 months. The study was designed to give immunotherapy drug Keytruda for those with a positive ctDNA but no evidence of recurrent disease on the imaging. Please note that this study was performed between 2018 and 2019 when pembrolizumab immunotherapy was not part of standard preoperative treatment for triple-negative breast cancer. And what is the result? Out of 208 patients who were registered, 161 patients entered ctDNA surveillance, and 7 patients relapsed even before the first ctDNA testing. And about 30% patients had ctDNA detected during the first 12 months. But far fewer patients than anticipated started intended immunotherapy treatment. About 72% were already metastatic at the time of positive ctDNA testing, and then it was substantially higher than anticipated. So only 5 patients commenced immunotherapy treatment, and none of them achieved sustained ctDNA clearance. Insufficient patients were treated in this study to assess potential activity of pembrolizumab immunotherapy guided by ctDNA. Important implication from this study is that sometimes detection of ctDNA and intervention may be too late. For very high-risk patients, we may need to start testing early, maybe more frequently, aiming to reduce the number of patients who have already relapsed at the time of first ctDNA sampling. So as of November 2023, ctDNA monitoring technique is available. However, therapy itself is not guided by ctDNA in early breast cancer. It may be disappointing you, but there are many ongoing clinical trials to change this practice pattern. Let me introduce you to several ongoing trials. First one is their trial, currently recruiting patients with hormone receptor positive, HER2 negative patients. Their trial enrolls patients with a stage 2 or 3 hormone receptor positive, HER2 negative patients receiving endocrine therapy with a tamoxifen or aromatase inhibitor. During routine clinic visits, patients undergo ctDNA screening, and if ctDNA is detected, but there is no metastasis on imaging, patients will receive more intense endocrine regimen. which is palbociclib and fulvestrant. This trial is to determine whether this new approach can actually improve relapse-free survival or versus standard care. What about triple-negative breast cancer? As of 2023, standard care for stage 2-3 triple-negative breast cancer includes preoperative chemotherapy in combination with immunotherapy for 6 months, followed by surgery. About 50 to 65% of patients have no residual disease at the time of surgery, which is a very good marker for a good long-term outcome. But they still receive 6 more months of immunotherapy. What happens if a patients have a residual disease at the time of surgery, despite very intensive preoperative chemoimmunotherapy? Those are high-risk group of patients, so we add oral chemotherapy drug called capecitabine for 4.5 to 6 months, in addition to immunotherapy. But how can we know if capecitabine is actually doing something for those high-risk patients? Is it working in an individual patient? Is it really enough? It is a difficult question. So there is an attempt to monitor ctDNA level to know if capecitabine is actually working or not in this setting. ctDNA guided approach may be able to tell us who really needs capecitabine. Here's another trial that focuses on this high-risk group with the residual disease after chemoimmunotherapy. In PERSEVERE trials, participants that are ctDNA positive with genomic target are assigned to one of these 3 groups and receive genomically directed therapy. This is a completely different approach than current practice, where everybody gets the same chemo drug. If this kind of interventional clinical trials show superior outcome versus current standard of care, then our practice pattern will change. ctDNA can be used not only for intensification of treatment, but also for potential de-escalation of treatment. We have learned negative ctDNA after curative treatment is a good prognostic marker. If patient can achieve that, can we skip more chemo or immunotherapy after surgery? This trial is to examine whether knowledge of ctDNA negativity influences patients' decision-making. If ctDNA is negative, is patient willing to accept no standard care capecitabine? It is a very valid question because chemotherapy is not easy. This is an example that ctDNA may actually impact on patients' decision-making. This is my patient, who is a 61-year-old woman with stage 3 breast cancer in both breasts, stage 3C in the left breast, stage 3A in the right breast, meaning extensive lymph node involvement in both sides. She completed double mastectomy, lymph node dissection, and 5 months of intensive chemo and radiation. Now it's time to start endocrine therapy. But after a long course of surgery, chemo, and radiation, she's finally ready to have some break and decided to pursue natural remedy. She didn't want to deal with the potential side effects from endocrine therapy. It is a very legitimate concern from her perspective, but I was also very concerned about her recurrence risk, given her initial presentation. Despite multiple conversations, she refused endocrine therapy, so I offered ctDNA testing. This is back in May this year. Her ctDNA came back positive. She got this result and immediately changed her mind and elected to take endocrine therapy. Subsequent ctDNA testing has remained negative in July, August, and September, and she's currently doing well. So positive ctDNA got converted to negative on endocrine therapy, and then we we are not detecting any evidence of cancer at this moment. So these are commercially available ctDNA assay products for minimal residual disease monitoring. NeoGenomics, Invitae, Natera, Foundation Medicine, and Guardant. They all can be ordered by your doctors, commercially available. More products are coming. Exact Science, the company particularly known for Oncotype in breast cancer, is also developing the MRD test, and a new validation study is ongoing. Myriad Genetics, which is a company well known for genetic testing for hereditary breast cancer, is also developing MRD testing platform for breast cancer. So it is a busy market, a lot going on. In summary, for early breast cancer, data have repeatedly shown detectable minimal residual disease to be associated with a poor prognosis. But it is not yet clear whether MRD detection by ctDNA can guide therapy escalation to improve patient outcomes. The results of interventional studies will be invaluable for patients and providers. Furthermore, it is also important to concurrently evaluate the impact of minimal residual disease testing on patients' anxiety levels, because there is a practical concern that testing for strong predictor for relapse without a known effective intervention may decrease quality of life by adding stress. I think this is absolutely very important to keep in mind until we have more mature data from ongoing interventional trials. When my patient requests ctDNA testing for MRD detection, I tell them multiple times that, yes, ordering is easy, but I have no proven therapy to offer if MRD is detected, but the imaging is negative. Let's move on to ctDNA. Uses in metastatic breast cancer. The analysis of ctDNA offers a wide range of information in metastatic breast cancer patients. We already discussed that it can provide a prompt diagnosis of disease relapse in previously treated early breast cancer patients. In contrast to early non-metastatic breast cancer, ctDNA is detectable in the majority of metastatic breast cancer, as circulating ctDNA level is usually higher. Fluctuations in ctDNA levels correlate with the tumor burden, which makes ctDNA as an excellent non-invasive tool for predicting treatment response and monitoring tumor evolution. What do I mean by tumor evolution? The genetic makeup of the tumor may change over time. Cancer begins with 1 abnormal cells. 1 tumor cell becomes 2, 2 becomes 4. During the process of cell division and proliferation, mutation occurs. More and more mutations occur as the tumor tissue grows, so the tumor mass consists of genetically heterogeneous cells. At present, the selection of breast cancer treatment is based on the analysis of tumor biopsy. However, the information obtained from the tumor biopsy is not permanent. Changes and acquired resistance that can occur during cancer treatment cannot be evaluated or analyzed in the original tumor specimen. Practically speaking, at the time of metastatic breast cancer diagnosis, patients often undergo an initial tissue biopsy to confirm metastatic disease and receptor subtypes, because 20 to 50% of breast cancers may undergo receptor subtype changing at the time of metastatic recurrence. For example, Patients who initially had ER-positive breast cancer taking tamoxifen can be later diagnosed with triple-negative breast cancer at the time of metastasis. But after that, serial tissue biopsies are not routinely performed at each time point of progression in the metastatic setting. Tissue biopsy is just not very convenient thing. We cannot keep on poking the patient. But if we just treat the patient based on initial biopsy, we could potentially miss a lot of information. Metastatic breast cancer that were exposed to multiple drugs may have acquired many different types of mutation. Genetically speaking, it is no longer the same cancer as the initial cancer cell, as you can see here in this picture. ctDNA can provide insight into the genomic makeup of the current status. Repeating blood tests is much easier than invasive tissue biopsy. So it is standard of care tool for identifying actionable alterations in metastatic breast cancer, where it is used to identify for targeted therapy. Detecting PIK3CA mutation in hormone receptor positive HER2-negative breast cancer means that we can use the PI3K inhibitor, alpelisib, Piqray. This drug is only approved for patients with the PIK3CA mutation. So if it's not checked, the drug cannot be used. If initial tissue biopsy was negative for this mutation, check it again using a recent blood specimen. If it is detected in the blood, here we go. Piqray becomes an option. ESR1 mutation is an important variant in ER-positive breast cancer. ESR1 mutations are found in about 30 to 40% of patients receiving endocrine therapy. And this mutation can be detected by ctDNA analysis. Detecting ESR1 mutation in patients with ER-positive breast cancer taking aromatase inhibitors, such as Femara, Arimidex, or Aromacin, means that patients may be developing resistance to the current treatment. And we know that fulvestrant injection may work better for those patients. This information leads us to PADA-1 trial. Currently, patients with ER-positive metastatic breast cancer receive an aromatase inhibitor and CDK4/6 inhibitor, for example, palbociclib or Ibrance, as a first-line treatment. We don't necessarily routinely monitor ESR1 mutation levels, although it may be happening in our patients. We continue aromatase inhibitor palbociclib until imaging shows progression. Upon clinical progression, treatment is switched to intramuscular injection fulvestrant-containing regimen. In this PADA-1 trial, patients on palbociclib and an aromatase inhibitor was serially monitored for emergence of rising ESR1 mutation levels, and upon detection were switched to fulvestrant early versus continuing the same endocrine therapy. And the authors demonstrated that early switch in endocrine therapy was associated with improvement in median progression-free survival by 3 months or so. However, whether such an approach improves overall survival results remains to be determined. So these results have not been practice changing at this time. Nevertheless, this study provides an important implication in ctDNA-guided management. In January 2023, FDA approved elacestrant for ESR1 mutated hormone receptor positive HER2-negative metastatic breast cancer. So again, ESR1 mutation is an important mutation to be checked. The SERENA-6 trial is assessing the efficacy of switching patients from aromatase inhibitor to new drug as soon as ESR1 mutations are detected. Again, whether this kind of ctDNA guided treatment will actually improve on patient outcomes is an important question to be answered. Earlier, I showed commercially available products for minimal residual disease monitoring. Here are some more examples of commercially available products for complete genomic profiling using liquid biopsy for metastatic breast cancer. And not surprisingly, of course, there are more products on the way. Hope I didn't cause you feel tired with too much information so far. And what is the summary of ctDNA uses in metastatic breast cancer patients? Targeted therapy is available if certain mutation is detected. Therefore, National Cancer Society guidelines recommends next generation sequencing test via tissue or ctDNA in effectively all cases of metastatic breast cancer. ctDNA is particularly promising due to logistical ease and reflection of current tumor status. At present, there are only a limited number of approved therapies based on genomic profiling. However, more are expected in the future. For now, ER and HER2 still remain the major important biomarkers. Genomic profiling is also important for investigational therapies and clinical trial enrollment, including for use of off-label therapies. Clinical utility remains uncertain since interpretation of this genomic profiling results remains complex. Moving on to future perspectives, we talk a lot about ctDNA tonight. Where are we headed from here? ctDNA sounds fascinating, but what are the obstacles and limitations? The reliable detection of trace amounts of fragmented circulating tumor DNA from a routine blood draws remains a major technical challenging. Before the clinical applications of ctDNA are widely implemented, several prerequisites such as reproducible and validated technique, a demonstrable clinical utility, and cost effectiveness will need to be met. At the moment, some large assay platforms are being used to perform analysis in different laboratories, but there are no standardized methods for quality assessment of each platform. And most clinical studies of liquid biopsies are retrospective and limited by a small number of patients. Unfortunately, it hasn't improved treatment yet, especially in early breast cancer. Despite the limitations, overall future perspectives of ctDNA promising. The inclusion of liquid biopsy in current research project and clinical trials hopefully changes clinical practice in the near future. We may be able to re-understand breast cancer and potentially generate new molecular classifications based on the presence of different ctDNA alterations. This is it for tonight. Thank you for your attention. I'll take some more questions if you have any questions. Thank you very much again.
So, Dr. Kang, one question is about insurance and whether insurance is covering this test or not.
Yes, important question. So, Signatera testing for MRD monitoring by the company named Natera is approved for breast cancer, stage 2, 3, and metastatic. So it has to be at least a stage 2B actually. This is Medicare. So commercial insurance still not universally paying for this. But as you saw on the slide, there are many companies that are competing. So all these companies trying to advertise their products. So a lot of times they don't send the bill to the patients. So they still bill to insurance. If a commercial insurance says, no, we're not going to pay for it, they don't usually send the bill to the patient. So if a patient really, really wants to know, I think it's doable. And then some companies have a financial assistance program. So for Medicare, there's a certain guideline for commercial insurance. It's still experimental, so insurance doesn't cover if you have a very early stage cancer, but usually they don't send the bill to the patient. I hope it was clear.
How expensive is this test?
So as I said, you don't usually need to pay, although insurance doesn't cover. I don't know if it makes sense. Company just it's up the cost just to expand their market share. So it's probably expensive, but I haven't had any patients who had to deal with the financial issues when they really wanted to know. Bigger problem is, what we do with the results. If CT doesn't show anything and then it's positive. So some patients, they wanted it, but then I give them all these informations, and then most of them, they didn't want the test to be done after hearing all of that limitations.
There's a question about your case study, wondering if this patient's on trial or whether this was just ordered off of a protocol, off trial.
No, this is my patient. It was not ordered on protocol. So all the testing kit that I showed you, it's commercially available. So not everybody needs to be on clinical trial to get this information. If you can be on clinical trial and then get tested, then actually, trial team can actually do something differently with the informations. But off trial, testing is still available, but it's unclear what to do with the information at that point. But when I give maximum treatment already, then I discourage patient to get testing, because I'm already giving you everything that I could in this setting. If it's a positive, there's no more treatment I can give. But that particular patient, she refused endocrine therapy when it was clearly indicated. So I used that just to show her how high risk she is. If she didn't start endocrine therapy, she probably had a metastatic disease soon. So in that case, I was able to change her mind, the study result.
And is that how you seem to be using the test, or are there other scenarios in which you would tend to use it?
Another scenario is that I had a patient who had breast cancer in 1995, and then she had a recurrence in the brain. So that was the only site of disease. We did the PET scan, but outside of the brain, she didn't have any other disease. So repeating brain MRI, and she also had a surgery for that brain lesion. So on imaging, there was not much to follow. And then I started treatment, and I wanted to know if treatment is working or not. So when there's no measurable disease on the imaging, but I want to know how treatment is working, I check it, and then it was positive. Then if we do it serially and then the number goes down, that kind of gives me an idea how treatment is working. So that's also another occasion I use this study.
Are there any more questions? Dr. Kang, this has been really informative, and you actually simplified everything. So we really appreciate your time tonight. And if there are questions from the audience, everyone has my email. They can email me at karen.sachs@inova.org, and I can get them to Dr. Kang. Wait a minute, let's see if there's another question. Oh, no, just thank you very much. And if you want more information about Life with Cancer programs or our services, visit our website at lifewithcancer.org. You can also call our Connect line at 703-206-5433. Thank you again, Dr. Kang.
Thank you very much.